Okay, it's recording. All right. So welcome to the last class of Psychopharm. We pretty much covered, I would say, 90% of what was on the syllabus. 10% I just think was not important. So I didn't really cover it, but it's okay. You're gonna learn about that anyway as the course goes through. I didn't make the final yet, but I will tell you what I'm gonna write a lot of questions on. So definitely know lithium, right? I love that medication. It's very important. Definitely know how to start it. So in the very beginning, why don't you guys tell me if you were gonna start me on lithium, what labs would you order for me? What are some labs you might order for me? Do you know? Randy?
Uh, yeah,
No,
I
just
needed. I was just doing it. I would do liver.
liver,
Um,
really? Why? But lithium is not metabolized. You could. I mean, it's not going to
I
be
don't
real.
know. I always do liver.
All
Hold
right.
on, I'm looking. Let me review.
All right. All right. Let me give you a hint. So lithium, Lithium. All right. So Li stands for leukocyte increase, right? So it can cause white blood
Oh,
cells. Could be
right.
good, it could be bad. So obviously you're going to check CBC. All right. T stands for thyroid,
Yeah. So
right?
right. That's right.
H stands for oh my God. I say TH stands for thyroid. IU stands for increased urination. So you could probably check for kidney functioning and check urine osmolarity to make sure that you're concentrating urine okay, right? Urinalysis as well. And M is like metabolics, just to make sure that that everything is okay. So if you can remember that. Lithium, Li leukocytes increase, so you would do a CBC. TH stands for thyroid. IU stands for increased urination, so kidney functioning. And M is, even though they say lithium doesn't really cause a lot of weight gain, it can. So I would probably still, counsel clients on diet, right? Metabolics rule. Remember, lithium has a lot of dietary interactions. So I don't know if I'm a college student and I'm eating a lot of ramen noodles every day because I'm broke and I have student loans to pay, what might happen to my lithium levels if I'm on lithium? If I binge on, high sodium ramen for like 2 weeks, is my lithium level gonna go up or is it gonna go down? What do you think? What do you think, Rob?
Up,
No, it's actually going to go down.
down.
Yeah. Increased sodium diet is going to bring lithium down. Decreased sodium diet is actually going to increase lithium because your body's going to retain lithium chloride as a salt, right? You can't tell the difference. Yeah. Because
Okay.
your body's going to want to excrete all the excess salt, right? If I eat a lot of ramen noodles. So all that lithium will probably leave with that as well. So increased sodium diet, decreased sodium level. Decreased sodium diet, increased sodium level. Because remember, your body's retaining lithium, right? Okay, thyroid. Make sure you do a TSH just so you actually understand what their baseline is. All right. Also check for what I missed.
Oh yeah.
Yeah, thyroid, kidney functioning because it's metabolized through the kidneys, right? And make sure that your GFR is okay. That's probably the best way to check for kidney functioning, right? eGFR, it'll tell you. Once it goes below 50, usually that's when we really have to have a serious talk about, um, if you want to stay in lithium or not. All right. Remember, age, as you get older, what happens to GFR? Does it go up or does it go down?
Down.
It goes down, right? So the older they are, just make sure. And you can always adjust the lithium level. Usually, as people get older, you can reduce the lithium dose. All right. Remember, lithium is usually dosed all at bedtime if a patient can tolerate it, right? The most common side effect usually is nausea, diarrhea, right? It can flare up skin problems if someone has cystic acne. It can definitely worsen that. If someone has psoriasis, plaque psoriasis, it definitely can worsen that. So make sure that you speak to the patient about that. Right? There's different types of lithium formulations. There's lithium carbonate regular, right? Which is the immediate release lithium, which has a half-life of about 18 to 21 hours. And you have lithium ER, extended release, all right, which has a half-life about 24 or longer. So there is debate whether which one is better for the patient. A lot of times, if someone has a lot of GI side effects, which one might be better, IR or the ER, and why? If someone has a lot of GI side effects, which one would you prescribe?
IR, the immediate release would be better.
No, it's actually not. No.
Oh, really?
ER is better because it doesn't peak as high, and ER is absorbed through the small intestine, right? Further down. Right? Immediate release, it hits quick faster, it's absorbed in the stomach lining. So if you have absorption in the stomach lining, usually you're gonna have more, upper GI side effects, right? Nausea, vomiting. ER tends to cause more diarrhea because it's absorbed late, a little bit further down the track,
Yeah.
right? That's a good way to remember. Depakote's the same way. If someone has, a lot of nausea, vomiting with Depakote, you give them the liquid form of it, that's absorbed through the stomach. If they can't tolerate that, you give them delayed release Depakote, DR. DR means it's going to be absorbed a little bit further down the GI tract. So they have less nausea, but there's also higher risk of, GI side effects, right? Diarrhea. So depending on what their side effects are, you would dose accordingly, right? So lithium, usually it started, 300 milligrams twice a day, to 300 milligrams 3 times a day. And then once you find that right dose, you move it all at bedtime. All right. Obviously, you do a level too. After about a week, you do a level. Once you do that level, you want to keep it between 0.6 and 1.2. All right. Maintenance dose is around 0.6, 0.75. It does vary a little bit based on guidelines, but my personal preference is 0.6 to 0.75 for maintenance. If someone's acutely manic, sometimes you go a little higher, maybe 0.8, maybe 1. But remember, it has a very narrow therapeutic index, so any interactions can cause lithium level to go up, right? What are some signs and symptoms of lithium toxicity? What would you see? What could you see? Coarse tremors, right? So people at rest and they're just shaking, right? Fine tremors is a regular side effect of lithium, right? Bilateral, low amplitude, high frequency tremors like this, low amplitude, high frequency. That happens with patients, all right? It can be exacerbated if they drink caffeine. So I usually tell them cut down on the caffeine use because it can make tremors worse. All right. And once you find a good dose that's stable for them, move it all to bedtime. But remember, once you move all the meds to bedtime, your kidney excretes lithium a little bit slower, about 20% slower. So I would probably reduce the lithium dose by 20% if you move it all at bedtime. Let's say, for instance, someone is on 600 milligrams at night and 300 milligrams in a day, right? That's a total of 900 milligrams. If you're going to move it all at bedtime, you would probably reduce it by what's 20% of 900, 180. All right. So do the math. Maybe 150, reduce it because it goes by 150 increments sometimes. Make it lithium 750 all at bedtime. And your level probably will be the same as 900 milligrams, twice a day. All right, give or take. Remember the trick I told you. If a patient isn't willing to adjust their lithium level and I think they need a little bit higher level and they're doing it twice a day, if I move it all at bedtime, technically I'm increasing the dose without well, it's unethical, but the patient should know that it's going to be raising the dose, but if you can get away with it, it's enough. And they'll probably feel better. All right. If someone has constant urination, right? Sometimes they can give them amelioride. That helps with that too. All right, polyuria, constantly peeing a lot. Patients sometimes will say, "Well, I get up in the middle of the night to pee since I'm in a lithium." What do you tell them? Don't drink. Don't drink before you go to bed. Right? Try to limit your fluid intake because then you're gonna have to get up and pee. Right? Try that first. If not, then you probably will have to do a level and then maybe add amelioride if you can. Right? Any questions? Lithium is the only medication in mood disorders that's been shown to reduce suicidality. If someone has a chronic history of suicide, lithium might be a good option. Make sure that at the very beginning, though, when they're still actively suicidal, you don't give them too much, right? Don't give them like a 90-day supply. Give them like a week supply at a time and have a family member give it to them. Right? It might take months to help reduce that suicidality. And remember, if someone stops lithium cold turkey, there's a rebound suicidality also. So you have to tell the patient that. All right. Please let me know if you ever want to stop the meds because we have to do a slow taper off of it. Even though I don't think it's a good idea, at least there's shared decision making, which we have to do it safely. All right. Lithium can also flatten the QT interval, so be aware. If a test said someone came with an EKG and that flattened T waves, right? Most likely probably lithium overdose. All right. Any questions with that? Lithium also can cause something called Epstein's anomaly, right? So if someone who's on lithium during that first trimester when the heart is being developed, it's a very low risk, but it's there, it's not zero. You let them know, hey, lithium could cause this, but we'll be monitoring it. Especially if the patient has chronic history of suicidality, lithium might be the best option for them, right? But it just has to be monitored and the mother is aware of the risks. Okay. Any questions with lithium so far? All right, Depakote. Know the levels, 60 to 120, about very highly protein bound, so it could be affected the way it works is affected by your plasma albumin. If your plasma albumin drops, there's a higher risk of you developing Depakote toxicity, right? Which can lead to hepatic encephalopathy, all right? Which your ammonia levels are going to go up. You're going to have a confusion, imbalance. You know, someone's going to be confused. It might be delirious. So definitely do an ammonia level. All right, Depakote is usually used for mania. It does have slight antidepressant properties for bipolar depression, but it's really mostly an anti-manic medication, right? It stabilizes from the top down, right? From the top down, stabilizes from the top down. It increases GABA. It also works on channels, sodium channels, right? Very teratogenic, so should not be prescribed. Actually, the new studies now shouldn't be prescribed to men or women of childbearing age, because men who are on Depakote and they get a woman pregnant, there's also a risk factor for the baby. So to be aware of that. I personally don't use it a lot unless it's the only medication that a patient's doing well on. All right. Depakote also, if it's combined with lamotrigine, which can happen, right? Because Depakote, like I said, stabilizes from the top down. Lamotrigine stabilizes from the bottom up, right? For depression. You have to titrate lamotrigine at half the dose at double the amount of time. All right, half the dose, double the amount of time. If someone's on Depakote and you're adding lamotrigine. Right, so half the dose, double the amount of time. All right, lamotrigine, make sure you counsel the patient on reporting any rashes that they see in the body because of what? A rash could become what?
Stephen Johnson's.
Very good. Yep. What's another name for Steven Johnson's? TENS. What does TENS stands for?
Toxic epidermal necrolysis syndrome. Is that
Very good. Yeah. Sometimes I like to tell them that name instead of Steven Johnson. Steven Johnson sounds like a fun guy to know, right? Who's Steven Johnson? Seems like a nice guy. If you say, well, please let me know about the rash because you can develop TENS. What's that? It's called toxic epidermal necrolysis syndrome. Right? You literally your skin peels off like a banana peel. You have to tell patients because sometimes they think it's a serious side effect. And you definitely don't want that to happen to your patients. Which is why once you see a rash, I usually stop the dose and give it a couple days, see if it goes away. All right, if it's a bad rash. It's when patients keep taking it. And also with lamotrigine, how many days can they miss a dose until they have to restart again? Do you guys know?
5?
5 days. Yep, very good. What about, don't confuse this with clozapine. How many days of clozapine can someone miss until they restart again? 3. All right, don't confuse that. Some students in the past used to make that mistake. Clozapine is a lot more riskier. Once you miss 3 days, you have to start from the beginning. Lamotrigine, 5 days, you have to start from the beginning. All right. It's a shame because if someone's stable on like 250 milligrams of lamotrigine, it could take months to get back to that dose again. But unfortunately, you can't just rush it back, right? Because the risk of developing Stevens-Johnson is very high. All right. Carbamazepine, anti-manic medication, can also cause Stevens-Johnson syndrome. So you have to check to make sure that the patient has what gene? Doesn't have a gene if they're Southeast Asian descent. HLA-B1502, all right? HLA-B1502, no carbamazepine for you. Unless I don't like you, then you give it to them, all right? Carbamazepine can also cause bone marrow suppression, so make sure you check CBC with that as well. So if you have someone like, I don't know why you would have someone on Depakote and carbamazepine, but if someone was stable on both, always check CBC more frequently because any meds that have the same side effects usually compound that risk, right? So multiple meds that cause the same side effect is going to be higher risk. I mean, it's common sense. Okay, carbamazepine levels 6 to 12. All right, those are the levels 6 to 12. Okay, definitely know your antipsychotic medications. I think it's important that us as psychiatric specialists, right? We're all going to be specialists, are very, very comfortable prescribing atypicals. Why? Even if you're not treating psychosis, you should still know because they're used a lot, right? Atypical antipsychotics are used in depression treatment as adjuncts, right? They're used in aggression for young kids. They're used in mania. They're used in depression. There's so many uses for them. It's almost like a jack of all trades that you need to understand the ins and outs of it, right? Definitely no risperidone, definitely no Abilify. Those are the two most used, especially in pediatric psych. They're the most studied. Okay, risperidone, I believe, I think is used as young as 4 years old. Right, in autism, irritability autism. Okay, side effects of Risperdal, obviously, you guys should know hyperprolactinemia. So Risperdal is very high risk of hyperprolactinemia, right? The reason why, and can anyone answer why? Why do you think it causes it more than all the other meds? You know the answer? I'll be very impressed if you know the answer. If you know the answer, you have to answer in 30 seconds. I'll give you an extra 10 points in the final. You can't look it up. It has to do with PGP. What's PGP? P-glycoprotein, all right? It's an efflux pump that pulls out toxins from your brain, all right? It's a very good substrate of the PGP pump. So what happens when it goes inside your brain, it gets pulled out. When it gets pulled out, it leaks into your hypothalamus, all right? It leaks into your hypothalamus, what's gonna happen? It's gonna increase prolactin levels. Right? Useless information, unless you go in Jeopardy, then maybe it'll be an answer. But if they ask that question in Jeopardy and you get it right, I want half the money. But risperidone, paliperidone, which is active metabolite of it, is notorious for causing hyperprolactinemia. All right. So symptoms of hyperprolactinemia for females, amenorrhea, right? Sometimes leaking from the breast, they'll leak milk, right? For men, gynecomastia, which is irreversible, by the way, even if you stop the medication. So make sure you check pretty regularly. Sexual dysfunction can also happen. All right. So hyperprolactinemia, you would do a prolactin level, a serum prolactin level, which for a non-pregnant, non-breastfeeding female should be below 10. All right. Males is even lower than that. All right. I've seen prolactin levels in the hundreds, actually. There was a female that had a hyperprolactinemia. She developed a prolactinoma, and that was the reason why. But the doctor was like, oh, no, it's the risperidone. I'm like, it's not the risperidone, because the risperidone will only probably raise it to like 30 or 40 or 50, and she was on a low dose. So they did a scan, and they found it's a prolactinoma. Normally, it's going to be like in the hundreds. If you see someone's prolactin is in the hundreds, send them to do a scan right away. All right. If they're doing well on the risperidone and you want to keep them on the risperidone and you want to normalize the prolactin, what can you add low dose? What? What's a PA?
Partial agonist.
Very good. Partial agonist, like
Like Abilify.
very good. Abilify. So that's the most evidence-based, low dose. Now, think about it. I told you guys before that Abilify has a very high affinity for the receptors. You're probably going to ask me, wouldn't it cause a risk of psychosis? Yes, it can. So be very careful. There's that risk too. So if someone's stable on, I don't know, risperidone 4, risperidone 5, and you want to add Abilify, don't give them Abilify 20 or Abilify 30, right? Because it's high affinity. It's going to bounce off all that risperidone at the mesolimbic area, and the patient's going to have rebound psychosis. What you want to do is you want to add slowly, maybe 2 milligrams for a couple of weeks, 5 milligrams, and then maybe a month or two down the road, recheck the prolactin again. It might take 2 months for it to start going back, but don't be too aggressive with the Abilify, because it's going to pull it off the receptor, and the patient's going to have rebound psychosis. You know what's going to happen? You're going to have a high affinity, high half-life medication that's going to be there for a long time, that no matter what you give them, it's not going to work. You understand? So if you go too high, too aggressive with the Abilify, it has a long half-life and it's high affinity. If they become psychotic from the Abilify bouncing off, it's like giving someone Suboxone, right? Once they have Suboxone, buprenorphine, I'm sorry, you can give them as much opioids, but that receptor is being bound by the partial agonist. It's not going to work, right? Especially if they need pain relief. That partial agonist is going to stick. Am I right or wrong, Robert?
Absolutely right.
Good. Just want to make sure. So you have to be careful about that, all right? So that happens something. So I've seen this happen in inpatient where, like, you know, more amateur prescribers like, oh, what's going on? I gave them Abilify and they became more psychotic. Yeah, they became more psychotic because you're an idiot. You gave the patient a partial agonist knowing that they were on a D2 blocker, right? It makes no sense. So when people say that, you just laugh to yourself and say, you're a moron. This is what happened. And you don't make that same mistake, all right? So please do not give someone a partial agonist if they're very psychotic and they've been on olanzapine and risperidone, because you're going to torture the other treatment teams. They're not going to be able to override that for a while. Like even worse, give them Abilify Maintainer. Now they have a medication that's going to be there for months, and you can't bounce it off because it's a long-acting medication and it's a high-affinity medication. right? You probably have to snow them with benzos. That's the only way to calm them down, especially if they're aggressive, all right? Okay, definitely no clozapine, right? It's the best treatment for treatment-resistant schizophrenia, which is defined as what? How many failures?
2.
Very good, right? 2 failures of antipsychotics. I would probably put them on a long acting just in case to disqualify them. Because the thing is, sometimes people will get put on clozapine prematurely. Maybe just to make sure they really did get Aquitrol, try to convince them to go on Invega Sustenna, at least for a month. At least you know if it's in there and the levels are fine, they actually tried it. Because you never really know. Patients will be like, yeah, I tried it. And they'll say, for how long? I took it for a month. But would they really take it for a month? Probably not. Maybe they missed a few doses and never hit steady state. So you can tell the patient, before we go on clozapine, which is a great medication, can we just try 1 month of, Invega Sustenna or 1 month of Abilify Maintainer, right? And see. Obviously, if they're not aggressive and not super psychotic, you could try it. And, obviously, Abilify is better for patients who don't need the metabolic burden of, Invega. All right. Olanzapine is also an important medication. Why do you think I like olanzapine so much? They call it clozapine's cheaper brother, all right? It's a little bit easier to prescribe. And at high doses, you do get some of the effect of clozapine. You can. So high dose olanzapine would probably be second best to clozapine, right? When I say high dose, I'm talking about above 30 milligrams a day, right? FDA indication is only 20. I do have a few patients that are on like olanzapine 40 milligrams. I do a level. Remember, a level of olanzapine is double the daily dose. So if someone's on olanzapine 40 milligrams, what would the level be if I did a level at steady state? How many nanograms per ml? 40 milligrams a day. What's double 40? 80, right? 80. Definitely know the difference between typicals and atypicals, all right? Typicals tend to have more D2 blockade, more motor side effects. So it's like Haldol, fluphenazine, haloperidol, fluphenazine. Atypicals are the partial agonists, the olanzapines, the risperones, the Abilifys, the Latudas, lorazepam. Okay. Know that there's a caloric minimum when you give lorazepam. What is it?
350.
350 calories, yeah. Yep. 350 calories. All right. Try to dose all your antipsychotics at bedtime. Why? Notice I said at bedtime, not at night. I used to say at night, but I realized there's some patients that work at exotic dancers and drive Uber at night, so you don't want to give them their meds before they go to work. All right, because remember the peaks is when you have the side effects. So you want it to peak while they're sleeping. Your basal ganglia is not working technically while you're asleep, right? So when your basal ganglia is not working, you're not going to have stiffness. So dose it all at bedtime. All right, let's see. Definitely know your pharmacokinetic interactions, all right? Big effing problems, bupropion, fluoxetine, paroxetine can cause big effing problems if you're not aware of them because they're very potent inhibitors of 2D6-384. And those are a lot of our psychiatric meds are metabolized by that, all right? No Wellbutrin, someone should have no history of seizures, head injuries, eating disorders, anything that can increase the risk of seizures, all right, Wellbutrin. Fluoxetine has the longest half-life out of all SSRIs, so it could be a problem because they're technically making someone, if someone's on Prozac and they take it and they hit steady state and it's good, stays in the system for a month, you're technically making them a slow metabolizer or a fast metabolizer of CYP enzymes. What do you think? If someone's on Prozac, they're technically making them a slow or a fast metabolizer? What do you think? A slow metabolizer, right? So any med that they're going to get is gonna have to be adjusted moving forward. So even if they have like many medical medications, that doctor needs to know this patient's on Prozac because all those meds have to be cut, right, accordingly. Except if it's a prodrug. If it's a prodrug, it's different. A prodrug means it needs to be metabolized for it to work, right? Like tamoxifen for breast cancer, or codeine, right? It becomes morphine. So it has to be metabolized first by 2D6. So another difference between a prodrug and a regular drug, all right? What else? I'm sorry, I'm doing all the talking, but do you guys have any questions? I'm just trying to cover, things that I think is important. You guys should know. Definitely no treatment options for patients with opioid use disorder. All right. We talked about that last week. So definitely know the difference between a partial agonist. Definitely know the difference between a full agonist like methadone, right? Long half-life. Harm reduction, definitely know those concepts. Definitely know the signs and symptoms of withdrawal. Like I said, if you want, pick withdrawal and then inverse it for the intoxication, right? Or memorize intoxication and do the inverse of it for withdrawal. It's up to you, whichever's easier for you. Right. Going back to clozapine, I'm sorry, make sure that you know how to monitor it, right? You should be doing a ANC. What does ANC stand for?
Absolute neutrophil.
Absolute, yes, very good. Absolute neutrophil count. Okay. Except if someone has Ben, then what's the difference? What's Ben?
Benign ethnic
Ethnic neutropenia.
And what does that mean? That means someone's white blood cell count is just normally low, right? Their body's adapted to that due to genetics. So you could do a genetic testing and then they can rule that out, all right? Because then the cutoff is going to be different. Then they can technically stay on clozapine even if the ANC goes below 1500. But you should have it documented. I realized too with females that if you do their CBC or ANC during the time they're having the menstrual period, it actually goes down. So I just repeat it. There was a female that we were doing it at the same time. Her period was coming every month, and it was always like 1400, 1500. It was always cutting too close. So I just moved it, and then we did it like a week later every month, and it was fine actually after that. So that can happen too. Right. So clozapine, the most dangerous side effects are severe neutropenia, right? That's why you're doing a neutrophil count. Myocarditis. So if they have chest pain, you usually order C-reactive protein and troponin I. Right? If those are abnormal, they usually send them for echocardiogram, and they will probably stop the medication. All right. Remember, you can't just stop clozapine cold turkey. You have to what? Replace it with something. All right. You replace it with another anticholinergic. Right? Whether it's going to be Benadryl or Cogentin, and you taper off that. All right. If not, they can develop anticholinergic withdrawal. I'm sorry, cholinergic withdrawal. All right, what else? ADHD, definitely know the pros and cons of using stimulants versus non-stimulants. All right. Stimulants obviously are, the mainstay treatments because they work pretty fast and the effect size is very high. Be careful of using stimulants with patients who have a known history of substance abuse problems or any family history of substance abuse problems. All right. If you do want to use a stimulant, let's say an amphetamine class, what would be a good option? You guys know? Which Adderall class stimulant medication might be good for someone who might have risk of substance abuse problems? Starts with a V. And I don't mean Viagra.
Vyvanse?
Very good. Vyvanse, right? Lisdexamfetamine. Lisdexamfetamine, right? There's a lysine on top of it, and the lysine inactivates it. In order for it to work, the lysine needs to be cleaved off. The only way lysine is cleaved off if you take it as prescribed, right? It has to be absorbed through your GI tract. We try to sniff it, or you try to crush it, you try to snort it, the lysine stays there and it doesn't work. Right? Similar understanding is like using Suboxone, right? The naloxone is there. If you try to use it any other way, it doesn't work. All right, just safety precaution. There is a newer one for methylphenidate. I just can't think of the name for it. There is a methylphenidate prodrug as well. I've never prescribed it. It's fairly new, but that is out too. Know the difference between amphetamine class and methylphenidate class? Amphetamine works inside the cell. What does it do? It reverses the what?
VMAT.
VMAT, right? Vesicular monoamine transport. So it's actually going to spit out more dopamine. Okay. No options for alcohol use disorder, right? Naltrexone, opioid antagonist, helps with euphoria, right? Did you ever hear that with that option? What is it called? Drink yourself to sobriety. You ever heard that before? You ever heard that, Rob? Drink yourself to sobriety? No? Why do you think that? Why do you think you should drink yourself out of sobriety? I'm being serious, by the way. I'm not kidding. Because you give someone naltrexone, right? And they don't drink. But the problem is, this is part of psychology now, right? The behavioral part of it hasn't really been reversed. Sure, you might not have the grip, but when you drink and you don't have the euphoric effect, it kind of trains your brain. Why am I drinking? It doesn't even feel good anymore. So that's what they drink yourself to sobriety. Go ahead, drink with naltrexone on board. You're not going to feel any. You're not going to feel the rewarding effects. You're gonna be like, why am I drinking? Right?
It's like giving someone Chantix, pretty much. Like you can
Pretty
still
much.
smoke as many cigarettes as you want. Yeah, it's not
Exactly.
gonna-
Yeah. So it's the behavioral part, the behavioral component of it. You start, well, it's not feeling good, so why am I going to do it? Right. All right. Disulfiram, all right, is used to. Just be careful. Obviously, if someone is medically compromised, you definitely don't want to give them disulfiram, right? There's an antibiotic that has a disulfiram reaction too if they drink alcohol. Which one? Which antibiotic? Do you guys know? Metronidazole, Flagyl. Right. So disulfiram obviously, is good too. It could be used, but be careful with patients who are medically compromised, right? Because it can make them very sick. And also patients who have a history of psychosis or family history of psychosis, all right? Because disulfiram also inhibits something called dopamine beta hydroxylase, right? Which converts dopamine to norepinephrine. When you stop that conversion factor, what happens is you have a buildup of dopamine in your synapse that it can cause people to become psychotic, all right? Definitely know the signs and symptoms of alcohol withdrawal, all right? Definitely know about Wernicke's encephalopathy leading to Korsakoff's, right? That's a thiamine deficiency. You can also develop Wernicke's not just from alcohol use, right? People who are chronic eating disorders, people who have anorexia, people who had bowel resections who can't absorb it. Those people are at risk of Wernicke's also. Wernicke's usually is reversible if you give them enough thiamine. Korsakoff's is irreversible, right? Korsakoff psychosis. If someone comes to you and they're having, psychotic episodes, make sure that you rule out any medical causes, right? Substance abuse, definitely do a detox, right? If they have a history of head trauma, I would probably order a CT scan, right? Sometimes they also do spinal taps to check if there's something called NMDA anti-NMDA antibodies to see, because your body can also fight off its NMDA receptors, and that can also cause psychosis. All right. Be careful if someone has a history of COPD or asthma and they have mania or psychosis. Why? It could be caused by their medications, right? Steroids. Long-term steroid use can also cause mania and psychotic symptoms. I've seen that before. People very sensitive to corticosteroids. Usually when you cut those steroids out the picture, it tends to normalize. All right, let's see. What else? Sorry, my mouth is getting dry from all this talking. Any questions? I'm trying to squeeze in everything we learned this semester in 1 hour, or 2 hours, but I don't know what's gonna happen. I'm not gonna ask a lot of questions on neuroanatomy and brain anatomy, so you don't have to worry about that. It's gonna be all functional psychopharm questions. All right.
What do we have to know for the sleep meds, the Z drugs, and all that stuff?
Oh, the sleep meds. Okay, so definitely know the 3 phases of insomnia. Yeah, you have initial insomnia, which is, you have trouble falling asleep. You have middle insomnia, which someone wakes up in the middle of the night, and you have terminal insomnia, which someone wakes up an hour or 2 earlier than they want to, right? Terminal insomnia is usually pathognomonic for depression, right? People who are depressed tend to have terminal insomnia. They wake up a little bit too early, and then they feel exhausted for the rest of the day. So initial insomnia, very easy to treat, right? Antihistamines, anticholinergics, right? The Benadryls, the hydroxyzine. I like hydroxyzine better because it's not anticholinergic. It's only antihistamine. So it tends to be a cleaner medication. Just be careful with QTC prolongation if you go too high. All right. Trazodone, if someone has comorbid depression, has insomnia, I'd probably try trazodone, right? If someone has comorbid insomnia with issues with appetite and they're not eating, they have no appetite, mirtazapine might be a good option. All right. If someone has comorbid ADHD is on an alpha-2 agonist like clonidine or guanfacine, do not give them mirtazapine because it's a pharmacodynamic interaction. You're giving someone an alpha-2 agonist with an alpha-2 antagonist, and none of them are going to work, all right? Be careful with that. If someone has middle insomnia, give them a long half-life medication, right? You can give them a Z drug like Ambien CR, controlled release, okay? By the way, Ambien, there is an adjustment when it comes to males and females. So females tend to metabolize zolpidem or Ambien a little bit slower, so give them half the dose. All right. So usually the recommended dose for men, I believe, for Ambien is like 10 milligrams. For women, it will be half that. All right. Mirtazapine also half that. Women tend to metabolize mirtazapine slower than men also, so half that dose. All right. Another one is Zolpidem, Lunesta, is also a very long half-life medication. So those are the 2 meds that I like for middle insomnia. There's actually studies that show that Isoplaquil and Lunesta also combined with an SSRI have actually shown to improve scores in depression. So it has antidepressant properties when combined with SSRIs. So let's say if someone's on, I don't know, Zoloft, sertraline, they're doing pretty well, but they have insomnia. Remember, SSRIs can actually worsen sleep architecture. Why? During the slow wave sleep or deep sleep, when you're in there, what happens is you're actually not supposed to have a lot of serotonin. It drops down, serotonin drops. But what happens is when you're taking SSRIs, you're increasing serotonin, so you're not getting restful sleep. Right? So people tend to feel, not as restful. They might even have more vivid dreams. That's a side effect of SSRIs also. People might have more vivid dreams, they might have nightmares. Sometimes it's transient, it goes away, sometimes it's not. Right? If it doesn't go away, sometimes I'll add prazosin, right? An alpha blocker. It helps with nightmares, right? Or you can add a 5-HT2A antagonist like trazodone or mirtazapine on top of that, all right? Be careful of giving someone SSRIs or antidepressant meds like tricyclics, SSRIs, SNRIs to patients who have a possible history of bipolarity, all right? Because it can cause it to get worse. You might have mixed features, they might have rapid cycling, and it also can probably worsen suicidality, all right? Let's see. Okay. Going back to antipsychotics, definitely know how do you treat acute dystonia, right? Acute dystonia can happen within hours, right? That's irregular muscle contractions, right? Very painful. The neck might get stuck, their eyes might roll up. Acute dystonia. Days to weeks to months, weeks to months, Parkinsonism, drug-induced Parkinsonism, tremors, flat-like facies, all right, abnormal gait. And even longer than that usually, tardive dyskinesia, right? Which would be treated with a VMAT2 inhibitor, right? Deutetrabenazine, valbenazine, all right? Those are some of the VMAT2 inhibitors that we use, all right? What else? To managing weight gain with medications, atypicals, particularly adding metformin, right? Pushing it up to 2 grams a day, right? Long-term metformin use also affects your body's ability to absorb B vitamins. So remember, check B12 and folate levels also, right? Chronic metformin use can lead to that, can theoretically lead to depression also. So if someone doesn't have depression and you have them on metformin for the weight gain they might have on olanzapine, I would probably do a B12 folate level, right? And check and see and supplement it, right? What else? What's the other one? I don't know. You guys ask me. I'm sorry. What's not clear?
Professor, as NPs, is it as psych mental health NPs, is it within our scope of practice to order metformin? Because we had done a paper on the health assessment, and the professor questioned whether that was within our scope of practice.
It is within your scope of practice. It is because there's numerous studies out there in psychiatry, and we're actually pushing all psychiatrists now or psychiatrist practitioners to prescribe it prophylactically. Look, in an ideal situation, if you work in a practice with primary care there, right? They're there in the same place, you can get the patient there. Sure, you can have them do it, but it would be a great disservice for your patient to wait for them to go to the primary care doctor and get a metformin prescribed. And honestly, a lot of the primary care doctors are not trained in that, and they'll tell the patient, oh, try diet and exercise. It's okay. We'll do metformin if you keep gaining weight. But this is a chronic illness, and by the time they put on 30 pounds, 40 pounds of the olanzapine, the metformin is not going to work anymore. So all the studies have shown that it helps decrease weight gain is concurrent. As soon as they start the antipsychotic, atypical, start the metformin right away. All right.
Okay.
Yeah, I've had numerous arguments with primary care where they'll tell the patient, oh, why is psych prescribing you metformin? You don't have diabetes. I actually have to educate them myself and say, hey, I know they don't have diabetes, but they don't. I don't think they have they don't appreciate how metabolically dangerous a lot of our psych meds are, right? Like olanzapine or clozapine. You really have to start the metformin. It is within your scope of practice. It is. It is. I prescribe metformin pretty regularly to all my patients on atypicals. Yeah.
And that's the same for Synthroid, correct?
Yes, yeah. Obviously, you're gonna document it, right? That it's treating a for Synthroid, I'm treating it's an adjunct to SSRIs, not working, right? It's if you go in the STAR-D trials, actually it wasn't Synthroid, it was T3 was the one they were using. Try Cytomel, whatever, T3. But they're very similar, right? So you can still use it. So same, like make sure you document it appropriately though. I'm prescribing metformin not for diabetes. I'm prescribing it for weight gain or metabolic side effects of the atypical antipsychotic, right? I'm prescribing propranolol not for hypertension. I'm prescribing it for akathisia or performance anxiety. I'm prescribing, thyroid augmentation for resistant depression, right? Just make sure you document that. And it will be within your scope. As long as you document it that way. Good question. Look, there might be a time where we can actually prescribe Ozempic for patients. They're doing studies now. Ozempic for, people who have a lot of inflammation and not responding to our traditional antidepressant medications because of all the inflammation and all of the obesity, right? They were actually studying Botox for depression too. Did you guys hear about it? It failed the trials, but there was initial promise that maybe Botox would be a good treatment for depression also. Initial trials actually showed some promise, but the later trials showed that it wasn't working. I was looking forward to that, to prescribe Botox for me and my patients. Any other questions? Definitely no metabolic syndrome, all right? Remember, I told you guys last time, fats, PH-ATS, P, blood pressure is going to be elevated. H, HDL is going to be low. A is abdomen. So they're going to have a waist circumference that's larger. T is triglycerides. And S is sugar. Right? So every month you see a patient, try to do a height and weight, measure their stomach, check their blood pressure, little things like that. When would you use Strattera for a patient? What's Strattera? You guys know atomoxetine. What is it? It's for ADHD, right? It's a norepinephrine reuptake inhibitor for ADHD. So remember, by increasing norepinephrine, the frontal lobe doesn't have dopamine reuptake pumps, right? It relies on norepinephrine. So by increasing norepinephrine, in the frontal lobe, you're actually increasing dopamine as well because they're false substrates for each other. So it also has benefits for patients who take a stimulant and they can't tolerate it for whatever reason, right? They take a stimulant, now they have really bad insomnia, or they feel the jitters, or they just don't want to take a stimulant because, it increases the heart rate too much. Maybe atomoxetine might be a good option. It also has some studies to show that patients who have anxiety comorbid with ADHD, atomoxetine is a good medication for that. All right, Strattera. So if someone has comorbid anxiety with ADHD, it's a good option. OCD, how do you treat OCD? By increasing dopamine or no? How do you treat OCD?
Is that fluvoxamine, right? Is the only approved one?
No, it's not the only approved one. No, Zoloft is approved for OCD. Fluvoxamine is only approved for OCD.
Oh, okay, yeah, okay.
Yeah. But you can use SSRIs, yeah. Sertraline, Flag, they're all can work, yeah. Be careful with fluvoxamine, it's a potent 1A2 inhibitor, right? So a lot of meds are 1A2 can increase. Also, viloxazine, Qelbree, which is a newer ADHD medication. It's also works on reuptake of serotonin norepinephrine. It can also increase 1A2. It's a 1A2 inhibitor also, so be careful with that. Right? So fluvoxamine and viloxazine are both 1A2 inhibitors.
And the doses have to be higher for OCD,
Yes,
right?
yeah. Sometimes super therapeutic, above FDA indication. Like I said, I had a patient on Zoloft 400 milligrams, and I had someone on Prozac 100 milligrams a day, which is above indication, but who's working for the treatment-resistant OCD. What else? What can I add to an SSRI to maybe help it work a little bit faster? A blank blank partial agonist. 5-HT1A partial agonist like Buspar, right? Remember, downregulation of 5-HT1A can help with antidepressant and anxiety, so you might add Buspar, all right? Buspar is metabolized by 3A4, so just be careful if someone takes anything that inhibits it, right? Buspar is a 3A4 medication. Definitely know the benzos, the general benzos, what they're for, all right? If someone has catatonia, which benzo is the most evidence-based to treat catatonia?
Ativan?
Yes, lorazepam, yeah, very good. We call it the lorazepam challenge. If someone's is going on a flight, I don't know, say someone's going to LA and they're really, really petrified to go on planes, which benzo might you prescribe them to get them through that flight?
Xanax.
Okay, good. Not Librium?
Maybe if they're flying to Australia, right?
Yeah.
A very long flight.
Yeah, that. By the way, Xanax also has some antidepressant properties. If you look it up, if you go on PubMed and you put Xanax antidepressant, it's actually shown to show some antidepressant. Like patients who have been on Xanax and an SSRI and they stopped the Xanax and they stayed in SSRI, their depression actually got a lot worse. They put the Xanax back on. So it does have antidepressant properties, yeah. And it has to do with its GABA A receptor agonism, right? So what's the difference between a Z drug and a benzo? The Z drug also works on GABA A, but which subunit? The alpha-1 subunit, all right? That helps with sleep. That's why it helps you fall asleep, but it doesn't have the anti-anxiety properties because the other subunits have to do with anti-anxiety properties. But also the addictive part of it is also the other subunits. So in theory, even though people can get it, they can develop an addiction to zolpidem. I've seen it, but in theory, it's supposed to be much less likely, right? Because it only works on the GABA A alpha-1 subunit, which helps with sleep. It's a hypnotic, but it's not an anti-anxiety medication.
Are there any sleep drugs that are not habit forming? Besides
Yes, there's a new class. Yeah, there's a new class of measures I prescribed to a few patients.
the
It's,
orexin?
orexin, yeah, orexin 1 and 2 antagonists, like
Mhm.
suvorexin, lamborexin, yeah, yeah. And the good news is I also prescribe these to patients who have a history of sleep apnea and they can't sleep. So this might be a good option for them. It doesn't hit GABA. All right. So orexin kind of helps keep you awake, right? If you look at the style book, it's kind of like a generator that when your other neurotransmitters drop down, your body starts secreting orexin, or hypocretin is another name for it. So when you give someone an orexin antagonist, it kind of shuts off that system and makes people fall asleep. Actually, there's many ways you can help people fall asleep, right? Blocking acetylcholine, blocking histamine, blocking orexin, right? Blocking serotonin, blocking dopamine to a certain extent can also make people fall asleep, right? So blocking neurotransmitters. And obviously the opposite. If someone needs to stay awake because they have narcolepsy, modafinil. It's a histamine agonist and also works weakly on a dopamine reuptake pump. Anything else that's not clear? Someone's on carbamazepine and an SSRI. What are they at risk for? Hyponatremia. Remember, carbamazepine increases risk of hyponatremia, but so is SSRI. So if someone's on SSRIs and carbamazepine, make sure you routinely, maybe every couple of months, do a Chem 20 and check sodium. All right. It causes something called symptom inappropriate ADH, which your body, is very, very sensitive to antidiuretic hormone. Your body retains the water, all right? And obviously, when water goes up, sodium levels drop. Someone's on Depakote and clozapine. What are they at risk for?
Bone marrow suppression.
What?
Yeah, yeah, very good. Bone marrow suppression. Yeah, so it's CBCs repeat more frequently. Yeah,
What did you say, Depakote and what?
and clozapine. Yeah, they could be prescribed. Let's say someone's on clozapine and you start developing myoclonic jerks, right? And you don't want them to have a seizure from it. You can add Depakote. It's a broad spectrum anticonvulsant. But just be aware that by adding that, you should also monitor CBC more frequently, right? Someone comes to your clinic, is on clozapine, and they're on Cogentin 3 times a day. What should you look out for? Someone's on clozapine, they're stable, not psychotic, but they're also on Cogentin 3 times a day, and the other doctor just forgot to stop it for whatever reason. What are some things you should look out for?
Constipation.
Yeah, anticholinergic side effect, very good. Constipation is one. Blurred vision, issues with concentration and focusing. Someone comes to your office, they're on Risperidone, and their primary care doctor put them on trazodone, and they're wearing sweatpants, they're sitting in your office like they have 3 legs. What should you be on the lookout for?
Priapism.
Very good, priapism. Someone has a history of being impulsive, not paying their rent, promiscuous behaviors, comes to you and they're very depressed. And they say, you know what, I heard about this medication called Prozac. Would you prescribe it to them? Why or why not?
No, because it could increase suicidal ideation, possible.
Well, what would you have to rule out though?
Bipolar.
Very good. Positive bipolar. Right. How do you tell the difference between bipolar and borderline personality disorder? It can look so a lot of times they get misdiagnosed a lot. There is cycling, they're both cycling, but what happens? Usually for bipolar, right? It tends to happen they'll be depressed for a couple of days and then manic for a couple of weeks or a couple of days, right? For borderline personality disorder, their mood changes within seconds, right? There is something called ultradian cycling, which if you work in pediatric bipolar disorder, you'll see that a lot. And I've seen that a lot in my patients too. Well, they'll cycle within like hours, right? But borderline personality, they'll cycle within seconds or minutes. And a lot of their cycling has to do with situations, right? I tried to call my boyfriend, I tried to call my girlfriend, and she didn't pick up the phone. She's definitely cheating on me. Now I'm really pissed off, right? Their mood changes that way very quickly.
Is there pharmacotherapy for borderline? No.
No, it's more just symptom, like, treating the impulsivity, treating the comorbid depression, comorbid anxiety, and then dialectical behavioral therapy is really one of the main choices there. DBT.
When I read this book called Dopamine, the Molecule of More, and they talked about instances where these men in their 70s were started on carbidopa, levodopa, and the increased dopamine made them so impulsive that they were losing their homes,
Yeah,
gambling. Do you see that a lot?
I do. Yeah, I've seen that with there was a patient that was put on amantadine, Symmetrol, which is a D3 agonist, right? They were using it because the patient couldn't tolerate anticholinergic medication, so it was a way to treat EPS. But the dopamine from it was making the person be more sexually promiscuous, actually. So be aware of that, like impulsive gambling, which can also happen with a partial agonist. So there is a box warning for Abilify. That if you look at it, it says can increase risk of impulsive sexual behaviors and gambling. So if you give someone a partial, remember, because it can increase dopamine also, it's a partial agonist. So maybe it might increase dopamine a little bit, and it might make the person more, risk taking. So just be aware of that. So a partial agonist could do that. So how, like, when you see a patient come, we're going to talk to you guys more about this when you get to the clinical part anyway, like 5, 17, 27, 37, as you guys move on. But try to, like, apply what you learned in this course. Like, okay, a person's coming to me and they're having low motivation. They might seem anxious. Okay, anxiety. Let me try to increase serotonin a little bit because serotonin will downregulate the amygdala, right? Person's having obsessive compulsive disorders, are constantly ruminating and stuff. Okay, that's a serotonin defect. Maybe there's not enough serotonin in the anterior cingulate cortex. Let me try to modulate that, right? Someone is having mania, let me try to block a little bit of dopamine or maybe increase GABA to calm them down, right? Someone is, having issues with attention focusing. Okay, that might be a dorsolateral prefrontal cortex issue. Let me try to tune dopamine and norepinephrine without worsening things, right? So you have to understand how these medications work and how they might counteract other things, right? So if a patient's having issues with falling asleep, maybe I have to be careful with giving them something that's too dopamine driven because that might make them too awake, right? Or might go against the sleep. Or someone's complaining of ADHD, then look at their medications. Oh, wow, you're on like 3 or 4 anticholinergic medications. Let's try to switch those out first before we treat your ADHD, right? So before you want to add something, look at the regimen and see if there's medications on the regimen that might be contributing to their symptoms, right? There could be drug-drug interactions. Right? Someone's dysphoric. Maybe they have a comorbid alcohol use disorder that no one's screened for. Or maybe trauma, right? That was never assessed for. Or an eating disorder that's never been assessed for and not treated, right? So if your meds are not working, I would always try to revisit the diagnosis and see if you missed something. Try to use a I know I talked about at the beginning of the semester, diagnostic hierarchy, right? If someone has pneumonia, are you just going to treat the cough? You're going to give them Tylenol for the pain? That's it? Right? No, you're going to treat the underlying, whatever the big umbrella thing. Same in psychiatry. So trauma can look like a lot of things, right? It can look like psychosis when someone's really triggered or dissociating. So rule out trauma first. If there is trauma, treat that, right? Is there substance use? Because substance use can look like a lot of things too. Treat that too, right? If someone has inattention, okay, are they anxious and they have inattention? Treat the anxiety first, because anxiety can lead to poor attention, right? Is someone also depressed and they're having issues with attention? Okay, treat the depression first. Try to go in that step-by-step approach, because if you go right to treating the ADHD, even though that's their chief complaint, you can worsen their anxiety and worsen a lot of other stuff. So you don't want to add a med that's going to mess up the other symptoms, right? So diagnostic hierarchy. See if there's trauma, see if there's substance use, see if there's an underlying mood disorder, and then, whatever's next.
The last section on Brightspace is for non-scheduled drugs, psychoactive drugs, and caffeine, nicotine. What do we have to know for that stuff?
Just know about caffeine is like, if someone's coming to you with anxiety, I would definitely do a check and see how much caffeine they're drinking. So it could be as simple as someone drinks like 3 cups of coffee and then you find out that their primary care doctor put them on fluvoxamine and they're still taking it. Right? And then that's increasing. That's why they're more anxious. So maybe cut down on that. Or maybe someone gave them a sample for viloxazine, right? That's also a 1A2 inhibitor. They can decrease caffeine because caffeine is a 1A2 substrate. That's why you're having panic attacks. Yeah, so caffeine use, alcohol use, all that stuff. Yeah. No caffeine's interactions with clozapine, right? So if someone's on clozapine and they drink caffeine, what's gonna happen? Clozapine levels are gonna go up or go down? What do you think? Clozapine levels are gonna go up, all right, if they drink caffeine. For lithium, if you drink caffeine, your lithium levels are gonna go down. So don't confuse that. Caffeine for clozapine, it brings clozapine levels up. Caffeine for lithium, it brings lithium levels down. Smoking, aryl hydrocarbons, would that bring clozapine levels down or bring it up?
Yeah.
Bring it down, right? It's an inducer of 1A2. So make sure you know that. Even though we don't prescribe them a lot, just know about monoamine oxidase inhibitors, right? There might be some patients that still come to you on it. I've only prescribed it once. But be aware of the tyramine, right? So wines, aged cheeses, that can all increase it. It can cause hypertensive crisis, so just be aware of that. There's a patch called selegiline, which apparently if you give them the patch, the dietary restrictions are a little bit more relaxed. Tricyclics could still be used, right? Sometimes neurologists will prescribe them when patients have comorbid pain, right? Because norepinephrine helps dull down the pain pathway, so help people with neuropathic pain, with depression. You might still see that. Duloxetine, SNRI, is also used for depression with some pain, right? Alpha-2 delta ligands like gabapentin, that's also used for pain, right? And sometimes people use it off-label for anxiety and for insomnia. You guys feel like you're absorbing the stuff, or do you think like it was too much material in a short amount of time? Be honest.
There's not enough time to do the reading, or to do all the reading. Yeah. But I think it's if you, I mean, I feel like if I go over things again, I am absorbing it. Yeah.
I know you guys have all of you guys have masters already, so that's why it's only 6 weeks. But the normal course I think is 16 weeks. Last semester was 16 weeks. And I can definitely go into more. If it was 16 weeks, I'd definitely go into more detail with a lot of stuff, but unfortunately it's just not enough time. But we'll touch on it again, in 517. I see you guys in that. But definitely watch the videos. Like I said, a lot of stuff I repeat, but if you hear it different times, it's good.
What should we know for the schedules?
Don't worry about that.
Okay, great.
I'm not going to ask you silly questions like this med is a schedule 1, schedule 2. I mean, that's irrelevant.
I know you said you didn't write the test yet, but I'm curious if you're gonna focus more on the new material for this test, or will it be like half and half?
I'm actually going to focus on everything I just went over today.
Okay.
Most of that stuff. But a few sprinkled in as extra, but majority of it's just stuff. I mean, what I told you guys today is already a lot of stuff, right? No clozapine, lithium. That by itself is a lot, but it's important. Yeah, I'll probably write the test by this weekend, so. I already have it in my mind, I just have to put it on paper.
I'm sorry I was late, and if you already answered this, will we
Sure.
have the results from our last case study before going into the final, so we kind of know where we're at before taking the final?
Sure. I'll do it by this weekend also, yeah. Like I said, most of you guys are gonna get 10 out of 10 for the case study. That's extra point for you guys. Unless you put something totally obnoxious, like I'm prescribing someone cocaine for the ADHD. But if you if you guys put something within reason, I'm probably gonna give you 10 out of 10. All right. Really focus on the material for the exam. Don't worry about it.
So for the finals, are we expecting 75 questions?
I thought it was 100 questions for the final. It said 75 on the syllabus? Should be 100.
Oh, okay.
Should be 100, yeah. Final's always 100 questions. Yeah.
Yeah, I don't think it's specified on the syllabus.
Oh, it's not? Well, it's gonna be 100 questions.
Okay.
Not unless you guys want less than 100. I think 100 is fair because you guys have more chances of getting more points. Yeah, I think 100 is fair because I can cover a lot of those subjects. So 50 might be too yeah. Like we did last time, we do a system analysis. So if a lot of you guys struggle on a certain question, we throw it out. So very fair. We threw out like 4 questions last test, I believe. Any other questions? Comments? Things I can do to make the course better for you guys?
Thanks for not giving us any group projects. I was losing my mind with with our other class. We had so many,
Oh,
so many
let's talk
group
to that one.
projects.
Oh, the diagnosing class?
Yeah.
Yes, thank you for that.
Oh yeah. Oh, that's more work for me to create group projects.
Mm.
Honestly, even the case studies, I wanted to get rid of them, but they wouldn't allow me to. Because honestly, I just want to teach Psychopharm, write you guys questions, and you guys answer it, and that's it. I mean, the case studies, I think that should be for later on, but that's all right. I mean, it's easy points for you. I mean, we give you the diagnosis already, and you should just cite stuff. It should be straightforward. Yeah. All right, so seems like you guys are doing fine. All right, like focus on what I told you guys are going to be on. There's going to be a lot of lithium, a lot of clozapine, a lot of the high risk meds. Know how to manage it. Know what the side effects are. Right. Know the mechanisms. Know what blocking dopamine typically will do. Know what increasing serotonin will do. All right. The increasing serotonin sometimes can cause GI side effects because a lot of the serotonin is in your stomach. So patients might complain about that in the beginning, right? But tell them usually your body will adjust to it, or you can take it with food. Be careful with giving someone antidepressants that they possibly have a family history of bipolar disorder, right? Because they could be, you could unmask it and make it worse, making them rapid cycling or give them mixed features. And yeah, I think you guys will be fine. Right? If there's anything comes up, just shoot me an email before the before the final. We can go over stuff too. All right. But good luck. Hope you have a nice weekend.
Yeah, me too.
Thanks so much.
Thank you.
Thank you very much.
Yeah.